Our next speaker is Dr. John Halperin. He is the chairman of the Department of Neurosciences at Overlook Medical Center and the medical director at Atlantic Health System's Neuroscience Service Line. Dr. Halperin's a fellow of the American Academy of Neurology, the American Neurological Society, the American Association of Electrodiagnostic Medicine, American College of Physicians, and the Royal College of Physicians of Edinburgh. Dr. Halperin.
So we're going to go from 30,000 feet down to ground level. And I'm going to tell you an interesting story, assuming I can figure out the buttons here. So, in words that I never thought I'd hear myself say, I'm from New Jersey. For most people, New Jersey conjures up images of hours of being stuck on the New Jersey Turnpike between three giant trucks working at 3 miles an hour. And what I have to tell you today is there's actually more to the state than that. And I work at a health system called Atlantic Health System, which is a 5-hospital not-for-profit system in north central New Jersey. We're actually due west of Manhattan. That picture on your left is from the roof of my hospital, seeing the Manhattan skyline. And you can see there are actually trees and hills, and it's actually a very pretty place once you get past the New Jersey Turnpike. Now, just to give you a sense of some of the challenges we face, so this is shot from the roof of my hospital, which is about 500 feet elevation, which is kind of hard for some people to imagine. For those of you in California, that's a speed bump on the road. For us, the town adjacent to us, immediately downhill, is called Mountainside, and we're called Summit. So people are really impressed by this 450-foot mountain. So what that means is we're blessed with urban-style traffic. The traffic jams can be quite impressive because we're a commuter community for New York. And at the same time, we have all these hills and valleys and suburban sprawl that make getting to our patients quite challenging and maintaining cell signal an interesting exercise. So with that by way of prelude, so our system sees about 3,000 stroke patients a year. We're, of the 5 hospitals, 4 are Joint Commission primary stroke centers. Overlook is a comprehensive stroke center. And our average door to needle at each of those hospitals is down in the low 40-minute range. At Overlook, in fact, we did an RCA last week because we took 44 minutes to treat a patient. So we're getting most of our patients treated very expeditiously. We spent a lot of time synchronizing the processes around the system so that all the hospitals are using very efficient processes in the emergency room. Now, just to give you a little more background about New Jersey and some of its, shall we say, idiosyncrasies, is we have a rather unique emergency medical system, which is that, I told you about Summit and Mountainside. Each little town or hamlet or intersection has its own BLS ambulance squad. So there are over 500 towns and other municipalities that own their ambulance systems. These are BLS certified. It's basically first aid squads, but those are the ambulances that bring the patients to the hospital. Superimposed on that, we have an ALS system of paramedics, for which there are 22 in the state. That's state regulated. The territories for each of those is regulated and is geographically defined. Of those 22, my health system owns 10 of them, and of those, 2 are dedicated to Overlook, and 2 of them are dedicated to Chilton, which is the other hospital I'm going to be telling you about. In this pyramidal system, not in a neurologic sense, those 4 paramedics relate to roughly 21 towns and municipalities worth of BLS squads. In the state, also being rather unique in its worldview, was a bit of ahead of the Joint Commission. So we have our own designation of stroke centers, and there are 53 of the 72 hospitals in the state. 53 are state designated as primary. Only half of those are Joint Commission certified. 13 are comprehensive stroke centers certified. Only 6 of those are Joint Commission. So there's a lot of honor system. I swear I'm a comprehensive stroke center, and so be it. Overlook, again, if you look at it from the state's perspective, we have 3 primaries, 2 comprehensives, but from Joint Commission, it's 4 and 1. So it took me years to figure this out. I still get it right only 60% of the time. So once we got our door to needles down to really good times, we had to look at what's the next step. And if you look at the sequence of how patients are addressed when they have a stroke, the top shows you the standard sequence that we're all used to using. And then a few years ago, the folks in Berlin started talking about the CT in the ambulance, and that struck me as an interesting approach. I have always believed that the difference between men and boys is the price tag on their toys, and this looked like a really nice, expensive toy to buy. So we dutifully hopped down to Houston and visited Fraser Ambulance. They're the folks who've engineered how to put an 800-pound CT in the ambulance. My grandchildren live in Houston, so it wasn't too onerous to go down there. So we went down, priced it out, scoped out what was involved, thought this would be really cool. I convinced the ambulance people that work with us that it would be a cute thing to do. I convinced my CEO it would be a good thing to do. Jim Grata very graciously allowed me to come down and visit Houston and my grandchildren again. Did I mention that? And spend a day traveling around with them, seeing how it worked. So I came back to Overlook, spent about a week talking to donors, and came up with the cash to buy one of these. And we started on the road to figure out what we could do with it. Now, the first challenge in terms of operationally how to deal with this is the staffing is a bit problematic. The biggest issue to start with is you need a neurologist to make the call if the patient's going to be treated or not. Now, Jim Grata actually rides around in the ambulance because he's semi-retired and he really likes doing that, but I can't afford to have my neurologist spend all day waiting to hop into an ambulance, so we obviously decided to go the telemedicine route since we use telemedicine for the Overlook docs to handle stroke throughout the health system pretty much. So we decided we would test just the technical capabilities of putting Telestroke in the ambulance, see if it worked, see how it helped, and just sort of started down that road, fully intending to use this as a stepping stone to buying the CAT scan. As we started to look at it, we started to realize that if we could use the Telestroke while the ambulance was moving, we could actually cut into the total sum of all that time and start to use transport time for evaluation. And originally we hadn't really thought about that, but when we found out that the signal was actually viable, we started playing with that. So this changes the equation a little bit, but if you think of the big equation of how we deal with patients, the first thing is the vehicle that's going to assess the patient has to get from wherever it's based to the patient, and then you have time on scene, and then everything after that is a fixed time. You can move the assessment, CT, and treating to before transport or after transport, but either way, the amount of time for that is constant. So really, the equation is the trade-off between how long it takes your vehicle to get to the patient and how much transport time is. As the folks in Berlin who've published the most data on this looked at, that they figured that a patient has to be within a 16-minute radius of their mobile stroke treatment unit for it to be worthwhile. When we started looking at what we were doing, we actually looked at it the other way, which is if the transport time is less than 10 minutes, you don't really gain much, and we should just get them to the emergency room. So we wanted to know about connectivity. We wanted to know how to make this work. In this instance, that weird two-tiered ambulance system actually worked very well for us. What we ended up doing was, since we had 2 ALS units at each hospital, we gave each of the 2 units an RX Express, and they would trundle off, meet the patient at the scene, clamp the Express onto the stretcher in the ambulance, and then off we'd go. So this is the basic system. Again, whenever someone calls 911, if it's a stroke or a life-threatening emergency, both BLS and ALS will get there, usually more or less simultaneously. What we do is when our ALS squad looks at the patient, if either the patient has a Cincinnati stroke scale that's abnormal or they just think it might be a stroke for any reason, they'll hook up with our teleneurologist. So that's on all 4 units. And then the study we did was we looked at all patients who came to Overlook, which is our CSC, and we chose Chilton as a representative community hospital. So we looked at all stroke patients brought to those 2 hospitals who got TPA starting in January 2015 through a couple of weeks ago is the most recent data. So then we had 2 groups. One was the patients who came with the Atlantic Ambulance paramedics, and the other group was everybody else. For the aficionados of studies, we did an intention-to-treat model, and our pre-specified primary outcomes were differences in door-to-needle and last-known well-to-needle. So Phil, if I could have my video, please.
We're here with a 55-year-old male. This is Ron. He had some sudden left-sided weakness this morning. It started about 30 minutes ago.
So Dave Peterson's one of our senior EMTs, and that's Gary Belt is the stroke neurologist on the screen. You can see he's doing it
Hello?
in stroke scale
Open your eyes wide.
while we're driving along.
And Dave, I want you to move your finger to Ron's left first and hold it there.
That's a volunteer, by the way,
Ron,
not a real
good.
patient.
Now to the right, please. Good. Ron, I want your hands
So 60
out front
seconds
like this.
altogether.
Gonna help him a little bit. Yep, now turn him over. Now close your eyes, keep your hands up. Okay, so this is a trip. Okay, now Ron, I'm with your right hand. I want you to do this one. Good, let's see what the left does now. Okay, so the left, okay, you can put it down. I see you have difficulty. Okay, let's try the other leg now.
Now, there's something here that proves we're in New Jersey. Watch carefully.
Go. Okay, so you can't hold it up.
We have a moving ambulance, and they passed him on the right.
We have an ETA of about 10 minutes right now. Okay, well, listen, what we'll do is I'll call ahead, and we'll have everything ready for you, Ron, and I'll see you in the emergency room when you arrive, okay?
Okay, thank you.
Thanks, Dr. Bell.
So that's typical of what we can do. That's going in and out of the hills and valleys of New Jersey. Signal comes, signal goes. It works. So just a little bit for the study aficionados. That's a map of our part of New Jersey. The blue areas are the areas covered by those ALS ambulances of ours. So Overlook is over here, Chilton's up here. New Jersey has a population gradient that goes high to low that way and high to low that way. So it's much denser around Chilton, less dense around where we are. So that drives a lot of this. So if you look at the patient populations, the patients who didn't come in through Atlantic Ambulance, we had 127 between the two hospitals over that 16-month period. We had 20 who had the express in the ambulance unit. Ages were the same, gender was the same. NIH stroke scale was a little higher in those in the who were in the express unit, but not statistically significant. Interestingly, the distance was significantly greater in those who didn't come in with Atlantic Ambulance, which really relates to the geography that they cover, but the travel time was identical. And this really comes about because of Chilton versus Overlook, where the travel times were identical, but the distance was substantially further at Overlook than Chilton, because Chilton is so densely populated that traffic really slowed you down. So in terms of the important thing, in terms of travel time, they're the same. In terms of different distance, they're a little different. What did we accomplish? Altogether, we've evaluated 111 patients in the ambulance using this technology. 20 of those received alteplase. Connection time in the ambulance was on average 7 minutes for those who were treated, 5.5 minutes for those who weren't. A third of the calls needed a reconnection because of all the ins and outs of cell service. As you hand off from one cell tower to another, it slows down. Sometimes it would drop, sometimes it isn't. Despite that, there were only 2 patients in the 111 where the neurologist felt he didn't get adequate information out of the communication. So 99%, it worked well enough for us. In terms of complications and outcomes, one of the express-treated patients had a hemothorax. He'd fallen with a stroke and had a bruise that bled. That responded to a chest tube, no further complications. No intracerebral bleeds in that group, about 4% intracerebral bleeds in the other. MRIs afterwards was kind of interesting. The roughly 20% in each group had normal MRIs afterwards. I tell people as we did such a good job treating it. Some of the other people say there were a lot of TIAs. I think as we see more and more centers getting to a 45-minute threshold for treating, this is going to be a very interesting issue to resolve. Is this treatment efficacy, or are we treating so fast we're treating more TIAs than we're used to doing? But time will tell on that. Now, the surprising part, that showed that we could do it. And so at that point, we're on track to do the CT in the ambulance. But what we started to notice with some of the earlier ones was that our door-to-needle time in the emergency room was getting shorter with these patients than it was with others, and we started to track that. So I have 2 graphs on your left there. The upper one is door-to-needle time, and the bottom one is last known well to needle. And It may be a little hard to see, certainly with these lights in my eyes, it's hard for me to see, but the lighter bars are the patients who didn't have the telemedicine in the ambulance. The darker bars are the ones who didn't. And with both graphs, you should be able to see that the darker bars are shifted substantially to the left compared to the others. If you look at the actual statistics of those who had telemedicine in the ambulance, the average door to needle, remember this is time in the emergency room from triage to treatment, was 32 minutes. In those who didn't have it, it was 45 minutes, and that was significant at 0.007. Last known well to needle was 93 versus 126, again, significant at 0.003. So clearly there was a difference here. At this point, we go into post-hoc data dredging, so it's statistically suspect, but we need to understand what fed into that. And there are a couple of differences in the populations that are worth keeping in mind. First is we have two different hospitals, although both are pretty efficient. Overlook has been doing this longer, so it's more efficient. We have patients who at Chilton always are treated by Telestroke in the emergency room. This gets to my point this morning. At Overlook, during normal working hours, 7 days a week, they're treated in person by the stroke team. After hours, they're treated by telemedicine. So one thing you see is if you just look at those treated in person, which means they were at Overlook. We only had 6 of those, so it's not very statistically compelling, but it's 24 minutes with Express and 6 in the ambulance and 35 minutes otherwise. So it's the same sort of order of magnitude, but the statistical significance isn't there because the numbers are so small. The other thing, if you just look at the patients who didn't have the Express in the ambulance, looking at the impact of having telemedicine in the emergency room versus in person in the emergency room, now you have a 35-minute door-to-needle of those seen in person by our team, 54 by those seen with telemedicine on the team. And this gets to a comment made by one of the speakers earlier, which is it's not the telemedicine that makes it faster, it's having the telemedicine give you access to a team that's really proficient at this that makes it go faster. And we have a very proficient team, and when they can get down there and drive the process themselves, it turns out to be a little faster than if they do it by telemedicine. Now, the numbers in the literature go both ways, and it's hotly debated, but this I found pretty compelling. We had the same docs doing the same thing in 2 different contexts. So I think that that is a real phenomenon. The thing that's interesting here, beyond that, is if you look below it, the number that's circled there are patients who had Telestroke in the ED with the Express, and the one above there is without the Express and seen in person. And with those 2 groups, the door-to-needle is identical. So having the Express in the ambulance negates that penalty you pay for having a telemedicine in the ED. The other piece in here is sometimes EMS will pre-notify us about a stroke coming in, sometimes they won't. And it turns out, one of the questions is the Express just a fancy pre-notification? If you look at the bottom data, which are the patients just coming into Overlook, the difference between the door-to-needle and the 2 groups is 39 versus 26, and that's statistically significant. When you pull in the Chilton numbers, that makes it just above statistical significance at 0.058. So part of this is pre-notification and getting geared up, but I think there's more to it than that. So here we had an interesting equation to do. Looking at the ambulance, the $1 million roughly upfront cost was actually pretty easy. It took about a week to raise that money from donors. They were eager to do it. The unit in the ambulance is roughly $20,000 a unit and about $8,000 a year between Verizon charges and connectivity charges. So we're going to need if we have the MSTU, we need the telemedicine there, so that cost is constant across the 2. In either event, we need a teleneurologist, but then if you're running a stroke unit with a CT scan, the unit has to have a licensed CT tech. It needs a licensed independent practitioner who can push the TPA in the ambulance and an EMT. If you take all those numbers, roll them up, and make it a 24/7 service, you're talking $1 million a year of operating cost, which is a lot harder to justify, particularly at the low numbers of patients who are treated. So as you look at the balance, the other thing with the MSTU is it has to be stationary when you do the CT and start everything else. You don't want a 800-pound CT scanner rolling back and forth in the ambulance while you're driving. So it becomes an interesting trade-off. The limitations on the in-ambulance telestroke, certainly there are connectivity issues, but they weren't insurmountable. You have the issue of being, if you're too close, you don't want to bother. But the scalability is there. The only thing that limits you is the number of units that you put in place. If you look at the volume, the MSTUs, the literature numbers have them treating 1 to 3 patients per week. They save on average 25 minutes per patient. Again, Berlin has looked at this most closely, and what they publish is because of conflicting demands for the ambulance with being called for several stroke patients at the same time, they were treating, during the times they were operating, they were treating 45% of the patients who needed it. So in their published paper, they said the minutes saved per population patient was 15 minutes versus our 13 minutes that we saved on average with what we were doing. The number of patients we're seeing is lower because we're in a much less densely populated area. From my perspective, operating an MSTU with our population density would mean having 24/7 people sitting there doing absolutely nothing most of the time, which is, to put it mildly, not in the spirit of the previous speaker. So we showed that telemedicine in transit works. We showed that on average it cuts 13 minutes off treatment time. Interestingly, it may be most advantageous when we have telemedicine in the emergency room rather than in person, assuming equally qualified teams. One of the things I didn't emphasize is the doc on the telemedicine in the ambulance is the same doc who's taking care in the emergency room, so it saves that handoff. Certainly from a cost perspective, greatly favors doing this model. Upfront costs are a no-brainer. So I think we have a solution that gets the advantages of the MSTU at a much more feasible and scalable approach. So I need to thank my stroke team and all the other folks who helped put this together, particularly the Kirby Foundation who funded it. So thank you very much, and I'll be happy to take questions.
That's very interesting. I got to believe there's a couple of questions on that because it is such a hot area, if for lack of a better term. And so we'll start here.
I was just wondering if you could talk a little bit more about the overall impact that this has had with your relationship with EMS.
My favorite, we do, there have been conversation today about positive feedback with EMS, and at each hospital we have a bi-monthly stroke meeting. And one of the things we do is whichever EMS squad had the fastest door to needle, we bring them in, give them certificates, thank them. So I was doing this at Chilton a few months ago, and the EMT, who'd obviously been an EMT for longer than I've been a physician, came in and his mouth was open, and he said, "This was so wonderful. I had the doc sitting there, verifying what I was finding, talking to me, telling me what was going on with the patient. I knew so much more. I felt I was having so much more impact." He was just absolutely ecstatic about it. That's been pretty uniformly the response we've had. We were worried at first that there'd be some pushback, who's this doc muscling in on us? But it's just so cool for them to have a doc as they're bouncing along the road and examining the patient together and coming to a conclusion and deciding on a treatment plan and knowing how it's impacting the outcome. We've just had nothing but thanks from them. One squad, before they adopted it, one of the volunteer EMTs is an attorney, and he said, "I assume you're going to indemnify us in case the thing flies off the stretcher and hits someone." I said, "We'll work on it for you." But other than that, we've had no objections.
Dr. Halperin, great talk. Thanks for all the information. Question on expansion for your programs in terms of other areas that you're looking and wondering if you're also training your EMTs and paramedics on mass casualty and other areas that might be a natural transition.
I mean, it's a no-brainer to extrapolate this to anything EMT sees, where the trauma, cardiac, any number of things, neurosurgery, just things where having a physician input earlier would be a great thing. I deliberately didn't start looking at this data until we had about 15 or 18 patients because I didn't want to do keep looking until the p-value works sort of thing. But now that we have this, and obviously there are still questions we need to answer, but it's pretty compelling to me, and we're talking as a health system how to start applying this in other areas.
Hey, great presentation. By the way, I grew up in Flemington, New Jersey, which is right there, and it is beautiful, so thanks for pointing that out. Quick question, if you step back even further from the EMS and you were to give either the public an app, InTouch Health app, or even a nursing home, or you're able to triage someone, would that time you say make a difference in neurology, in stroke, or not worth it?
It's an interesting question. I think the biggest barrier we have right now is with patients or observers recognizing that this is something to worry about. I still see patients who say, my arm was numb, I went back to bed thinking it would get better. I'm wondering if they had an app that they could query. Obviously, there'd have to be a human being at the other end of that. Would they be more reluctant to do that and get help, or would it speed that initial step that's the one that we don't have control over? It's an intriguing question, and it may well be worth a test.
Right, and the clarity was around would it make a difference on the clinical outcomes? Because if you open up my chart or any of the EMRs to the patient, you get a flood of calls, so you're going to get a flood of calls. But if you can appropriately triage them to a call center or a stroke center, assume you can do that. I'm just curious if shaving 5 or 10 minutes off that, shave the ER response time, the EMS response time, will that make a difference? We'll sort out the other stuff. But.
So in theory, if you look at the TPA response curve, it should. In reality, I've started looking at it in terms of the broad outcome measures that we have in administrative data sets. I don't yet have MRS data on outcome on enough patients to know what the difference really is and what with the comparator, but that's certainly something we're looking at.
Thank you very much.
My pleasure.